Good afternoon, everyone. So I'm going to speak on this topic of amniotic membrane graft in ocular surface disorders. So as we know, this human amniotic membrane is the innermost layer of placental membranes. D. Roth first of all described these placental membranes to repair conjunctival defects. There was low success due to highly immunogenic chorionic rejection. Then Sosby used chemically preserved dry amniotic membrane called as amnioplastin for the treatment of ocular burns. And Kim and Seng, they reintroduced the use of amniotic membrane in ophthalmology. So we know anatomy of the amniotic membrane. So there are amniotic membrane and the fetus are derived from the same cellular origin. So this amniotic membrane, it supports, nourishes and protects fetus during 9 months of gestation. The basement membrane of the amniotic membrane resembles that of conjunctiva and provides substrate for growth of epithelial progenitor cells. This facilitates epitheliation for persistent epithelial defects with stromal ulceration. It promotes goblet and non-goblet cell differentiation of the conjunctival epithelium. This amniotic membrane stroma contains many protease inhibitors which help in reducing the stromal inflammation after amniotic membrane transplant and also decreases corneal neovascularization. So we can have so many clinical effects because of amniotic membrane, like anti-adhesive effect, bacteriostatic, wound protection, epithelialization, and there is a lack of immunogenicity, so that's why it is well taken. So this is how we prepare in our department this amniotic membrane. Video not running. Can you run this video, please? I'm sorry, it was running in the preview room, I don't know. VLC.
Would you like to reload again, sir? Then we can have the next talk.
I think run with VLC.
Yeah.
Sorry for delay. So basically, there is a modified Delbaco medium, that is a medium that is used. So then we have this millipore filter. Then after taking placenta from the normal cesarean section, so that is very important. Then all the clots, they are removed. Then this you can see placental membrane, they are being separated. And this tray then is containing this Delbaco medium. Then after removing, it's very simple to remove. Then we put in this tray where a lot of antibiotics, antifungal drugs as recommended. So they are put, and then these are thoroughly washed, and all the clots, they are thoroughly removed. Then on the millipore filter, we can just attach them, and then we can cut various size, then put in the this Delbaco medium where we are preserving at -80 degrees centigrade in the deep freezer. So then you can use like from one patient you can use for 6 months. So many patients, like 40-50 patients, you can use this by one per patient. So that's very easy to prepare. So and very cost effective also. So what are the various clinical applications for this amniotic membrane? So like there are so many endless condition where you can use it, but few conditions which I'm going to highlight, like pterygium, then pseudo-pterygium, then various wound, bleblic in glaucoma surgery, scleral melt, lid reconstruction and orbital reconstruction, and simple limbal epithelial transplant as well. So like there are few specimen patient where we use them. Like this was a child, 10-year-old, having a firecracker injury. Because of that, he developed extensive symblepharon. So this symblepharon was removed. The ocular motility was restricted. So after this removal, and putting the amniotic membrane, you can see the motility also well restored, and it was very deep fornix also. Similarly, in symblepharon, all these patients, sometimes they have a lot of symblepharon due to chemical injury or some other conditions. So there you can just remove them, and then you can put either conjunctival graft or maybe amniotic membrane also. When sometimes there is a bilateral chemical injury, there conjunctiva will not be available. So in those conditions, this amniotic membrane is a very useful thing which can help. So in these patients, it is going to help a lot when we are not able to have conjunctiva from other patient. Similarly, pseudoterism formed after extensive other conditions where you will have this membrane formation. So once these are removed, then you can replace them with amniotic membrane. So there is a one condition where there is a sometime corneal fistula formed. So there is a perforation, then that perforation gets epithelialized, and then it doesn't heal whatever you do. So in these conditions, just freshen up the edges of the perforation and then put amniotic membrane multi-layered graft. So if you put that, then definitely it will seal. Similarly, persistent epithelial defect due to any cause, like post-PK patient, many patients they develop, then there are viral keratitis. In those conditions also many times this defect doesn't heal at all. So in these conditions, if you apply amniotic membrane, the epithelium defect, it heals very nicely. So it's a very good indication where any epithelial defect which is not healing, just apply amniotic membrane, it will definitely heal. Then thermal injury also, sometimes they come with superficial thermal ones with a lot of, you can say, epithelial defect only. So in these conditions, if you put this amniotic membrane and give topical steroid, it will nicely heal without causing any vasculation of the cornea. Stevens-Johnson syndrome, again, is a condition where there is a lot of scarring of the conjunctiva with symblepharon, dry eye, so many limbal stem cell deficiency, this lid margin deformities. In these conditions, it is very important that we have to take care of local ocular inflammation. So what we can do, we can just put this amniotic membrane and give topical steroid. So you'll have nice ocular surface because of amniotic membrane. And then this complication of symblepharon, they will not happen in these patients. So sometimes very rare condition, like we had one patient with porphyria cutaneous tarda, where there was necrotizing scleritis and keratolysis also happening. So in these patients, you can't do immediately keratoplasty. So just you have to give some tectonic support. So multi-layered amniotic membrane, if you can put in the immediate phase. Later on, you can do therapeutic graft. So this patient also helped. And there are scleral melts also sometimes. So these also can be taken care by multi-layered graft. So it is a just transient management. Later on, you will require optical keratoplasty as well. SLET is a very common condition nowadays where due to limbal stem cell deficiency, so it's very good surgery. So where Dr. Sangwan described, so this is a very good technique where you need amniotic membrane and it gives very good results. So you can see this patient having this chemical injury. After that SLET, the cornea is absolutely clear. So there are a few other conditions where there is a corneal thinning. So sometimes amniotic membrane may help in these conditions where you're not able to do graft immediately. So even DELC also in combination with amniotic membrane graft, it definitely helps in certain conditions like Moran ulcer, then certain corneal opacities, viral keratitis. So you can mix DELC with amniotic membrane, so then healing will be very fast and very easy. So of course there are few limitations also, like if there is a total limbal stem cell deficiency, then it will not help. Severe aqueous tear deficiency, then diffuse keratinization, severe neurotrophic keratopathies, stromal ischemia. In these conditions, it may not help that much. So to conclude, this selective use of amniotic membrane, it can show encouraging results in various ocular surface disorders, and it can restore stable and non-inflamed ocular surface in these situations. And in moderate to severe ocular surface disorder, amniotic membrane in combination with limbal stem cell or transplant or SLET can give excellent results in restoring near normal ocular surface. Thank you very much.